Now it's my privilege to welcome Dr. Alka Sehgal, whom I've known for a long time, and it's nice to see her she's now heading the Department of OBGYN at Government Medical College Hospital. And she's a young and a very enthusiastic clinician as well as a researcher. So I invite her as to moderate this next session. Please, Alka.
Yeah, thank you, Dr. Madhu. And thank you, Dr. Nija, for inviting me to this as a moderator. A very, very important topic for all of us. For this session, it's my pleasure to introduce two esteemed speakers, both from the prestigious institute and my alumni Postgraduate Institute of Medical Education and Research, Chandigarh. And to save time, I shall introduce both of them together. The first speaker is Dr. Madhumita Premkumari. She's a consultant in the Department of Hepatology, PGI, and having worked at Research Center of National Significance on Antarctica and Ocean, I'm sure she has a lot to share on evidence-based medicine, which is a must-know for all in medicine today, specifically because we are submerged in the era of consumerism. And the topic has a lot of legal implications on practicing physicians. The second speaker for the session would be Dr. Meenu, who, apart from her excellent academics, is a well-known figure as a pediatrician and a pediatrician pulmonologist, more specifically, as well as for telemedicine, both nationally and internationally. We are fortunate to have information directly from her on Cochrane analysis, meta-analysis and systematic reviews, which is very close to the heart and is in continuation with our previous talk, that is how to search. Thank you. Now I invite Dr. Madhumita.
So I'm here to talk about evidence-based medicine and clinical practice guidelines. I hope that's visible. All right. So I have no relevant disclosures. The first thing that is a straightaway segue from Dr. Bhatia's talk is that once we come across a patient, and if you're planning a study altogether, it's a different thing. But when we look at patients, how do we practice medicine? And slowly over time, our approach towards patient care has become more and more research oriented, or applying what has been learned from clinical research. So what evidence-based medicine and evidence-based practice is essentially integrating whatever is the available evidence in the literature, integrating new research with available clinical expertise. Is really important to know what can be done at a particular center, because not everything is available at all sites. So the best available clinical expertise at the site. And of course, the most important in this triangle of evidence-based practice is going to be the patient information and values, because if the patient does not want to participate in a particular intervention, there's no point suggesting that that is the best evidence available. For an excellent example is, I'm a hepatologist, and offering transplant is not really acceptable to a lot of our patients. So the very fact that it is cost effective, it is having the best outcome for a particular study, but people would not accept it. So evidence-based practice is also incorporating the ethics of giving a certain medication or a particular intervention. So patient values are equally important when taking any decision in evidence-based practice. So what is the PICO approach? The PICO approach refers to an integration of the patient and the population, whatever is the planned intervention, what is the alternative medicine that is available. So it would require us to ask a clinical question, to access all the knowledge that is available by doing an excellent PubMed search or any database search with the available filters, to appraise which is the best quality of evidence that applies to your patient. So it has to do with looking at all the available knowledge and funneling it to decide on an intervention to a particular patient. And then one applies the intervention or applies the research, and then one also, that it doesn't just stop with prescribing the medicine. It also goes on to look at the analysis of what the outcomes were and whether they met our or our patient's expectations. So the PICO approach, looking at the patient vis-a-vis the population, from which that patient comes, the interventions that are available, the comparators, and the outcomes are all about evidence-based practice. For example, this is the Digital Education Society, and a lot of us would be dealing with menopause or PCOS. So a question comes if there's a PCOS woman coming to you for treatment, and you find that the patient has insulin resistance. So the question would be, what would be the best treatment available for this patient with PCOS, with diabetes? So which drug should I prefer? What if she has deranged liver function tests? What if she is morbidly obese? And then one decides on the specifics of intervention, whether it is drugs or diet or lifestyle. So let's take it case by case. So appraise the evidence. Dr. Bhatia has done an excellent job informing us how to do a good Boolean search with all the filters so that we know exactly what is the relevant evidence to my patient. For example, if I'm getting a younger woman, I would tend to look over things that relate to fertility, which relate to hirsutism or acne, which would be the reason why the patient has come to one. And in an older individual, I would be looking in terms of fatty liver disease, cardiovascular risk. So the patient in relation to the population and age group would determine what is the evidence and what filters I would apply. And what is the way to look at the evidence? Well, the EBM pyramid starts right at the bottom with clinical reference tests, which are updated every 5 to 10 years. So that's not good enough, which is why it's at the bottom of the table. And as one goes up, we would see applied research from labs. And this is important here because it relates to the COVID vaccine. There is very little clinical trial data. So clinical trial and RCT and case control, we don't have it for COVID vaccines. But from the knowledge that we have from applied research from labs, we are advocating it to the entire world's population. So the EBM pyramid has a lot of fluid levels. And as one goes up at the right at the top, you would see systematic reviews, because in a systematic review, somebody's already done the job for you, or for praising the evidence, giving it a grade, and determining its significance. And when one looks at clinical practice guidelines, you would note it's somewhere in the middle. So not really important vis-a-vis the evidence, because clinical practice guidelines is often disguised in a way with expert opinion and recommendations to which there's not much evidence to support it, and we'll come to that. So this is the evidence-based pyramid, and one looks at all of these databases, whatever is available. It also means that everyone should have access to all knowledge, which means that although PubMed is free, abstracts are free, but to access an entire paper, one requires access to literature. Not everyone stays in an institution like PGI where everything would be available. Hence comes the question of freely available knowledge so that evidence-based medicine can be practiced. But now what has happened is the lines have kind of become a little blurred. Although as we go up this pyramid, the quality of evidence appears to improve and the risk of bias goes down, because in a case report and series, they could just be anecdotal evidence. So there's a lot of bias. The person's clinical opinion would also affect it. A systematic review is when and we will be looking at the Cochrane database with the next speaker, the risk of bias goes down because one has to follow a certain method to grade the evidence, and then it is one derives value to a particular, assigns a value to a particular study when the review is finally analyzed. But now we decide, so appraising the evidence, when we come back to a PCOS woman, we decide, well, should I give metformin? The patient has insulin resistance. What is the clinical significance of a particular outcome? What is the hierarchy of evidence that suggests metformin is good? Would I prescribe the same drug to all of my patients? What will happen in terms of the outcome? Will she reduce weight? Will she gain fertility? Will she overcome the insulin resistance? But when one looks at the newer, the evidence-based pyramid, we'll see the lines are kind of blurring, because a good quality case control or cohort study is often as good as an RCT. So because a systematic review is actually going to be only as good as its components. If the individual studies in a systematic review or meta-analysis are of not any are not of a very good quality, there's a lot of bias involved, then the review itself would have skewed results. So please appraise the evidence as it relates to your individual patient, and that's really important. Not all reviews would be great. So how is the grading of recommendations done? So if one looks at any particular study, a systematic review or a randomized controlled trial is placed above in the EBM pyramid. So the level of evidence is generally good because there's been a case cohort, there will be a control cohort and an intervention cohort. So in a question of metformin in a PCOS woman, there would be a systematic review of all the trials done on metformin. Someone would have done it, someone would have done a meta-analysis and given you an opinion. But does it relate to your own patient? That depends. So these kind of data generally provide good evidence and they get a recommendation of grade A. But cohort or case control or case series gives reasonable evidence, but the level of recommendation would go on as there could be a risk of bias. Expert recommendations are very poor evidence, although one would say that so-and-so has excellent many years of clinical practice over time, unless it is supported by evidence, translating into practice is different. And this is what goes against conventional dictum. Evidence-based medicine means one should have the science to speak up for one's practice, not just belief. Let's take an example. So this PCOS woman comes and says that I have heard from a friend that taking gluten-free diet is going to be good for me. So how does one confirm or refute it? So one does a good PubMed search and looks at whether a particular kind of diet or a particular kind of herbal medicine is actually going to help. So we find this on the PubMed search and we see that there is no high quality evidence to support any particular nutritional supplement or herbal medicine. So you can go back to your patient and say that there's not much evidence to support it. It seems anecdotal. So maybe taking calendula tea or chamomile tea or sticking to a gluten-free diet may not really help. Another example, will metformin or lifestyle modification help in PCOS? This is a systematic review and a meta-analysis. It's relatively recent, and one can actually look at the results of this trial and see that definitely, in terms of the outcome, a lifestyle plus metformin modification has resulted in lower BMI, lower subcutaneous adiposity, and improved menstruation cycle as compared to just lifestyle plus placebo. So there's a control group, a comparator, and the intervention which we were thinking about, which was metformin. So on the basis of these two searches, one could say that there's not much use of the patient's preference of a gluten-free diet, and there might be some benefit to a complete holistic lifestyle modification, weight loss, and use of metformin. So that's the way one goes about medicine. Coming to another thing that one reads in clinical practice guidelines, what is the great quality? So if there is a high quality evidence, it means that the authors or the writers of the practice guidelines are pretty confident that there is a unique benefit of metformin over and above lifestyle modifications. So they will assign a grade. So if there is a moderate or low quality in a CPG, then one would have to cast some aspersions that maybe in the future, if there are better quality studies, our level of recommendation will change. Please remember, as time goes by, recommendations change. And an excellent way to look at this is about all the drugs that have been coming through the last 1 year for COVID-19. HCQ is great. Oh, no, it's not. Remdesivir is great. Oh, no, it's not. And so on and so forth. And finally, we are left pretty much the same way we started with. But all of us have enthusiastically done it on the basis of currently available evidence. So evidence-based practice changes. Please remember, it is not set in stone. Another way to read it, many of the times when they don't write 1A or 2B, the level of recommendation is 2, quality of evidence is moderate, so it's 2B. If the level of evidence is very low, like but the experts recommend it would qualify it as 2D. Another way to represent this is 1 and this is 3. So in this is obesity, increased adiposity and abdominal adiposity is associated with hyperandrogenemia and cardiovascular disease. So it is recommended that PCOS women should be screened for adiposity by measurement of the BMI and the waist circumference. Level of recommendation very high, level 1. And what is the evidence? So 3, which is pretty good out of 3 out of 5. So this is another way that evidence is given, and that's how guidelines are to be read. So this just shows it low level quality of evidence, and that other than A, B, C, D, and the
I got you.
Another thing is to remember what is a clinical practice guideline, what is a position statement, and what is a consensus report. So a practice guideline would frequently have individual members of the panel going through doing a systematic review and then basing their recommendations and grading the quality of evidence. So that would be a complete review. A position statement would be given by a society to say that this is what we think is best for now. But this is not always evidence-based. For example, if one would talk about September 2020, all the position statements of infectious disease societies would have said that remdesivir is the best treatment for COVID-19 as per current evidence. So this would change with time. Consensus evidence and drafts the report. So again, the level of recommendation is poor. So please remember to look at each of these and read the fine print. Lastly, you have to look at the patient values and circumstances. If a young PCOS woman is coming, then maybe she's not concerned about fertility at that time or metabolic bone disease or liver disease. She might actually just be concerned about having acne go away. So the patient preferences and the clinical circumstances also dictate practice. The second thing is, if one looks at a study, one has to look at external validity. If I'm looking at a paper which is talking about surgical outcomes in PCOS women, and I'm trying to apply that to a patient who's an outpatient who's come to me with PCOS, hyperandrogenemia, and acne, no correlation. So the the study's external validity also has to be checked. Another thing is clinical and statistical significance. So you can have a paper which says that, oh, with metformin, the sugars have come down from 140 to 132 milligram percent after 3 months of use. It's statistically significant, but it makes no clinical sense because the patient is not in a euglycemic or desirable range, which is going to ensure that insulin goes down. So clinical and statistical significance are completely different parameters. If we have large population-based study and there is a drug, say telmisartan, which reduces the blood pressure by 5 millimeters of mercury, and our patient's blood pressure is 160 by 90, reducing it to 155 by 85 may not actually have any clinical significance. So please learn to interpret all studies properly. The p-value of 0.001 does not always have clinical significance. So choosing the right intervention in evidence-based practice is actually like choosing the correct sari in a sari shop. There are a lot of saris available. Different age groups might walk in to buy one. Colors would be different. So choose something that is required for your patient, not necessarily latest is best or latest is greatest. So first, identify the problem and the process and see what is the priority of our patient, what is the priority of clinical outcomes at that point. The patient might be worried about acne and we are worried about diabetic control, so that's equally important. Perform a systematic review and appraise the evidence that's available. Prepare a profile for every outcome. So we are looking in terms of curing the acne, getting hyperandrogenemia out, and ensuring euglycemia in our PCOS women. So that would be prioritization. The next thing is to look at the grading of the quality for each outcome. So if I'm looking at metformin, metformin may not improve acne, but it might help with the adiposity, it might help with the euglycemia and the glycemic control. So the quality of evidence would depend on what is our outcome measure. Decide what is relatively important. Naturally, for me, it will be most important to get rid of the hyperglycemia and then balance the benefits and harms. One must inform the patient that there might be hypoglycemia, there might be interactions with other drugs. So please inform the patient before any intervention. So after a net cost benefit analysis and the patient discussion, then one implements, and on a follow-up, one looks for the outcome. So these are the steps of evidence-based practice. So please incorporate evidence-based medicine in your clinical practice. It requires one to be continuously updated. It requires one to be critically able to separate the grain from the chaff and decide what is clinically relevant, not just statistically significant, but it is time consuming. It might also result in evidence-based paralysis. If one is continuously looking at PubMed, it might delay intervention. So it's important to keep oneself updated overall all the time. Like Dr. Bhatia suggested, get a PubMed mailer or join a mailer database that keeps you updated or at least sends the abstracts of relevant articles. And also check for the conflict of interest statement. Very often pharma is supporting a lot of medical research, and we have pharma-based research which is coming into big journals like NEJM and Lancet. Their editors have themselves told about the pressures that the editorial industry is under. Please read the conflict of interest statement and don't be paralyzed because there's so much evidence to trawl through. Look at what is relevant and incorporate in the practice. So thank you so much. And that would be the end of my talk.
Thank you, Madhumita, for an excellent presentation and excellent conclusions. With that, I'll invite Dr. Meenu. Meanwhile, I'll just say that what Dr. Madhumita has presented, somebody has also commented, and I too agree with that it is very relevant to even everyday counseling of the patient. And one should not shy away from admitting that not everyone at all times can be updated. So there is a need for updating the knowledge, and one can always share it with the patient that you may take a little time for that. Thank you. Thank you, Dr. Madhumita.
Can I start?
Yeah, welcome, Dr. Meenu.
Okay. Good evening, everyone, all the old friends and the new ones. I'm really privileged to speak about Cochrane today because I've been associated with this organization for, I think, last about 25 years since its inception. And I'll be talking about, although Madhumita has already introduced the concepts of evidence-based medicine, the definition is it's a science of turning clinical problems into research questions. And as she said, split it up into PICO. And then accessing, appraising, applying, and auditing evidence from scientific research findings to solve clinical problems. So accessing means going to the library, getting the articles, doing PubMed searches and other searches. Appraising means after you have the articles, you go through, you read them properly and appraise the scientific quality of the evidence. And then you apply the findings to your patients. And after you have applied those findings, you audit what's the result in terms of its cost effectiveness, or even otherwise, what are the risk-benefit ratios of those particular interventions. And all this is being done to solve clinical problems, and the things always keep getting updated. This is just a slide to show that as the years since graduation increase, our knowledge of current best evidence goes on decreasing. So, and this is actually a result of a systematic review. And what somebody had written in the chat box, we should keep updating ourselves. Now, this is a evidence-based practice timeline, just a historical. I'll just spend 10 seconds on this. This is R.T. Cochrane, and in 1972, he had written this book on effectiveness and efficiency, random reflections on health services. And you can consider him as father of evidence-based medicine, and as of today, at least of Cochrane, because Cochrane collaboration and Cochrane Library is named after him. He's a British epidemiologist who was active during the Second World War, and as a student had walked the streets of London carrying placards that all healthcare should be free, and we know that NHS is entirely free. Then we had Dave Sackett, who was a professor at McMaster as well as at Oxford, and he actually gave the definition of evidence-based medicine. Gordon Guyatt, a professor of medicine at McMaster's, has actually given us this term of evidence-based medicine. And then Sarian Chalmers, I think many obstetricians would know him because he's the obstetrician who made this landmark decision of starting this Cochrane collaboration and held the first Cochrane colloquium at Oxford. So after this, several centers had developed all throughout the world, and this has actually percolated into child health also. And in fact, pediatricians and obstetricians were actually the first people who started doing, there was a database of systematic reviews in perinatal medicine and the Oxford database. And that was the first database on evidence-based medicine, which was there. And that's why, this logo of Cochrane actually is derived from one of those systematic reviews, which were done on preterm birth because of premature rupture of membranes, and people giving steroids for that. The Cochrane collaboration is a global independent network of over 36,000 researchers, professionals, patients, carers, and people who are interested in health. And they respond to challenges of making systematic reviews. Now, we've all done reviews, during our writing of thesis and writing of papers. Sometimes we just do reviews and we write up, like for example, our review of literature, like a narrative review. Now that sometimes lacks a focused question. So what is a systematic review? Systematic review is something which has a methodology, which has a focused research question. And this attempts to identify, appraise, and synthesize all the empirical evidence that meets the eye and specify eligibility criteria to answer a given research question. And researchers conducting systematic reviews use explicit methods aimed at minimizing bias in order to produce more reliable findings that can be used in decision making. So what is a Cochrane review? Cochrane review is actually a systematic review, and this is a systematic review that is published in Cochrane database of systematic reviews, which is now known as the Cochrane Library. And that has followed all the methods which are given by the Cochrane for conduct of a systematic review, which is considered to be a quality systematic review. There is a Cochrane handbook, which is easily downloadable from the Cochrane website. And the methodology of conducting Cochrane reviews is given in Cochrane handbook. And from there, if you have a researchable question, you can pick up the methods, and after your review of literature or your initial library searches, you can, which also would have a definite methodology, you would continue to follow and do the Cochrane review. Now, there are different types of Cochrane reviews. There are intervention reviews, which assess the benefits and harms of interventions. For example, when Madhumita was talking about PCOD, then metformin is one of the interventions which may be considered to be helpful in preventing or treating this disorder. Now, diagnostic test accuracy is something which is based on diagnosis of a particular condition, in which you may have a gold standard, and the test which is under consideration is compared against that particular gold standard. For example, in COVID times now, we have RT-PCR, which can be considered as a gold standard. And then there are antigen tests, which may be considered as tests being tested against a gold standard. Then there are methodological reviews, which address issues which are relevant to how systematic reviews and clinical trials should be conducted and reported. And they are purely based on methodological issues. Then there are qualitative issues, reviews, which synthesize qualitative evidence to address various aspects which are other than effectiveness. Then prognostic reviews address the probable course or the future outcome of people with a health problem. So the Cochrane reviews base their findings on the results of studies. They use certain quality criteria, and the most reliable studies will provide evidence for making decisions about healthcare. Now, this picture shows the contribution of various groups. The Cochrane Library is actually constituted by several Cochrane review groups, and they do related, they're related to topics. For example, pregnancy and childbirth is a group which you would be interested in. And as you can see, this is the fattest group probably, and has contributed maximum number of systematic reviews to the Cochrane Library. So all these new review groups are also coming up, and they are, for example, Cochrane is at the moment very, very focused on COVID research, and there is a separate kind of channel which has been set for this. And nowadays people are conducting what are known as rapid reviews, and there is a methodology which has been defined for that, which means that you can do a little bit of quicker reviews. Otherwise, you need about 6 months to do a systematic review. So this is a picture of the Cochrane Library homepage, from where you can actually access the Cochrane reviews. You can access the trials, and there are more resources which are of the type of evidence summaries. There are Cochrane answers. There can be other databases which you can get a link to. So you have to surf through this library to find various resources which are there. So Cochrane Library is actually produced by the Cochrane Collaboration, and these days it is being published by Wiley. It is evidence-based. It's a single source bringing together international research on the effectiveness of interventions. Over 6,000 Cochrane reviews. The impact factor was nearly 8. The last one which has been calculated. It's a reliable source because it adheres to a strict methodology. It is up to date, and Cochrane reviews are updated very, very regularly, so that the evidence which has accumulated that would get incorporated into the reviews. They are easy to use, and actually flexible viewing and searching functionality, including mesh, which was told by one of our previous speakers, is there. And in clinical queries in PubMed, you can actually find systematic reviews, randomized controlled trials, and in fact, some of the genetic databases also. So in the Cochrane database, you have Cochrane database of systematic reviews, Cochrane database of review effects, Cochrane Central Register of Controlled Trials, Methodology Register, which contains methodological studies, Health Technology Assessment Database, and NHS Economic Evaluation Database is also there, which gets into economic evaluations. And then about the Cochrane collaboration and the various Cochrane collaborative groups, you can get this information from the Cochrane database. So who benefits from these reviews? It's basically all patients actually also review and benefit, and they're actually the consumers and health professionals at all levels, health researchers, health policymakers, caregivers, pharmaceutical industry, and of course patients who have. So this is, the logo which I was talking about. In 1972 was the first RCT on prevention of perinatal death by antenatal corticosteroid therapy for fetal malnutrition. And in 1991, there was a meta-analysis which showed that steroids lower the death risk by 30 to 50% in patients who are born by due to premature rupture of membranes, and that became the logo of the Cochrane collaboration, this meta-analysis. And this is actually a forest plot, which is on that. This particular pyramid has already been shown by Dr. Madhumita. I will not go into this. So the Cochrane process is also like any other systematic review. You define the research question, and then competence of the author team is actually judged by the Cochrane review group, to which you actually submit the title, and there is a title registration form, which you can get from that group. Then you write a protocol, and this protocol will have a PICO statement of the research question. It will have a plan of the search strategy. It would describe the methods, the statistical methods, and all other methods which will be used. It will undergo peer review process, a very, very strict peer review process by the reviewers and the editors, and then it goes into publication. And once so this is also this is for protocol, and then protocol is developed further into a systematic review in software called the RevMan. And this RevMan is also downloadable from the Cochrane library. And after you have done the searches and screened the results and included the studies which were supposed to be included according to inclusion criteria, you've taken care of the risk of bias of included studies by using risk of bias tools which are available. Then you have extracted and analyzed the data. And RevMan actually gives you a software. It's a software which gives you forest plots, it gives you heterogeneity, it gives you all kinds of plots which are required. Then you write up and submit. Again, there is an editorial process which leads to peer review, revision, copy editing, and then a Cochrane review is published. But the life of a Cochrane reviewer is not easy. It is actually full of trials. And as you can see, there are randomized control trials, but then there are some other kind of trials also which may happen. So one has to be extremely careful about conducting Cochrane reviews and be very, very firm about the methodology. With that, I end. Thank you very much. If there are any questions, I'd love to answer.
Thank you, Dr. Meenu. It was an excellent presentation, and I'm very sure many of us would be incited to be, not only we have been using Cochrane data, but I think many of us would be incited now to, do some quality research, so that if not as a participant of Cochrane data preparations, we should at least do a research paper which is privileged to be included in a good Cochrane data. So I'm sure at least that's a message and that's a pledge which I take, so that at least you do some good quality papers which are accepted amongst the Cochrane data. Thank you.